Vision. So these are how your visual fields appear projected on your retina. So there's a sharp area there for the macula. And then there are different quadrants assigned for if this is your left eye, this is your right eye, and this is this small area known as the fovea for sharp vision. So the macula is your central vision, and these are your peripheral fields, visual fields for the nasal part, and this is the temporal part. This is superior, this is inferior. So these are the superonasal part, meaning for the nasal half, there's a superior part, and for the nasal part, there's an inferior part of the retina. Then on the sides, you have the temporal retina, superior part, and this should be inferotemporal. Sorry. Okay, so those are your visual field projected on the retina. So the first thing that you need to check is, does your patient wear corrective lenses, or do they need corrective lenses? And you can test this by checking with a pinhole. So you can create your own pinhole with a sturdy piece of cardboard and then make a small hole using a nail, and then clean it so you can use it. So commonly, you have refractive errors when they cannot see the smaller letters on your pocket Snellens or pocket Jaeger charts. They don't see all the lines on their on reading. What happens if they have a enlarged blind spot? So usually we're not aware of these blind spots. They're usually located here in the inferior temporal retina field. But the moment they become quite obvious, the patient notices that there's an enlarged blind spot where nothing is in their vision. That could be a sign there's something wrong with their optic nerve. So it's an early sign. Or they notice that their visual field seems to be narrowing. They're developing tunnel vision. So this is early. Early part if the optic nerve is already being damaged, before it completely blacks out, with a completely blind visual field. And then you have this example. When you have bilateral visual field problems, it means they're no longer involving just the optic nerves themselves. The problems could be already here at the optic chiasm. So, for example, a tumor growing out of the pituitary gland will compress on that optic chiasm where the crossing fibers for the temporal fields of vision are crossing. So more on that later, I'll illustrate that. So I'm just demonstrating the different things that you can encounter when you're examining patients for their vision. So here is an example of an MRT line way of demonstrating where those visual fields go to. So illustration number 1, those coming from the nasal halves of your retina will cross at the chiasm. And if you go back to here, those nasal halves of the retina actually perceive the temporal halves of whatever you see. And conversely, whatever we see with the with the temporal halves of our retina sees the nasal half of the image that we're looking at. So the loss of the vision here in the temporal visual fields tells us the crossing nasal fibers are being compromised. So that's what I'm trying to say here. Whereas the retina for the temporal halves of the temporal halves of the retina do not cross, and they happen to see the nasal halves of a picture. So I'll demonstrate it later. So nasal fibers cross, temporal fibers do not cross. And the crossing is illustrated as the optic chiasm over here. But whether they cross or they don't cross, they all end up in the geniculate, the lateral geniculate nucleus on the other side. So the right temporal retina and the left nasal retina are end up in the right lateral geniculate nucleus, and vice versa. The right nasal half fibers will cross together with the non-cross fibers of the left temporal half to end up here in the lateral geniculate nucleus. And there will be an obstacle for the lower fibers. The lower fibers will have to move, the inferior fibers will have to loop around the lateral ventricle's temporal horn, whereas the parietal fibers have no obstacles. They'll go straight into the calcarine sulcus. So these are the superior fibers. They did not have to go through any obstacles. So these are the superior fibers going to the calcarine sulcus, whereas the lower fibers within the temporal lobe over here will end up in the lingual gyrus in the temporal lobe, the lower lips of the calcarine sulcus. Okay, feel free to ask later if you're getting lost in our MRT. So what happens if there is a lesion, for example, here only in one eye? So as a rule, if only one eye has a problem, then the problem is only at the level of the eyeball itself or the optic nerve, because the other eye doesn't have any visual field defect. So we call these defects scotomas, and they are a clue that whatever the problem is, it is before the two optic nerves fuse to form the chiasm, the optic chiasm. An example here is when one eye is blind. So when one eye is blind, that still tells us that the problem is at the level of the retina if it happened to get detached, or in the optic nerve. So if there's some form of optic nerve damage, like loss of the myelin sheath, or if you took out your eyeball, as we were talking about earlier. Here, if the problem is at the optic chiasm, we are damaging the nasal fibers of both eyes. And knowing that the nasal fibers of the eyes see the temporal halves of any picture, you will get the so-called bitemporal hemianopia. This tells us the lesion is at the chiasm. Smaller chiasmatic lesions can involve only the lower parts, or like the, if you have only the superior nasal fibers involved, then you have this incomplete bitemporal hemianopia, which is, in other words, a quadrant anopia, bitemporal, because you're interfering with the quadrants of the superior nasal fibers. So you can go over this over and over and over again in case you get lost. If it so happens to involve the inferior nasal fibers, which happen to see the upper half of any image that you see, you'll get this so-called bitemporal superior quadrant anopia. So anytime it is bitemporal, meaning it's on the temporal halves of your vision, that tells you the problem is at the optic chiasm, always. So chiasmatic lesions are bitemporal, whether it's a complete half or a quadrant, whether it's inferior or superior. So that's for optic chiasm lesions. If it is beyond the chiasm, so anything post-chiasmatic, now we get the so-called homonymous visual field defects, meaning the absent visual fields are on the same side. Like here, it's both on the right side of the person's visual field. So this is a right homonymous hemianopia, because there's no more vision on this side, on the right side. So these are post-chiasmatic because they are after the optic chiasm. Since a lesion in the optic radiations is still post-chiasmatic, the same pattern is seen. So if it's a large lesion that destroyed both the temporal radiations and the parietal radiations, you still get that same homonymous hemianopia, which is post-chiasmatic. Same thing if it is in at the level of the calcarine sulcus on one side, since it is post-chiasmatic, the same visual field defect will be seen, a homonymous hemianopia. So from some nuances here, if you damage only one optic radiation, like for example here the inferior or the temporal radiations, you get the so-called homonymous superior quadrant anopia, or better known as the pie in the sky. So there's a missing pie in the sky with people who have problems with the inferior or temporal optic radiations. And the opposite is true if you have a postchiasmatic lesion in the parietal optic radiations. You'll get something like this. So if it's in the left parietal optic radiations, because it sees an inverted image of the opposite personal body field, a personal space, it is on, if this is a left parietal optic radiation problem, then it should be a right visual field defect, which is inferior quadrant. Okay, hopefully you can go back and forth and replay this finding, so you'll finally get it. Okay, at the same time, if it's here on the right um, inferior or temporal optic radiation, it gives you that pie in the sky on the left side. Okay, and then if you have a bilateral hemianopia, that's a whole anopia, a complete anopia, that is blindness. And if you remember what I showed you there with that discussion about what is not the Edinger-Westphal, the light impulses will bypass the lateral geniculate and go to the midbrain, so that in patients who have damage to both occipital lobes will still have a reactive pupil to light because of the bypass, the light that managed to find its way into the tectum of the midbrain.
Who would you like to send this message to?
Okay, so the in some people, they have zero visibility except for a tiny spot here where the macula is, the macular part of your vision of the fovea. This happens in vascular cases where it's actually a bilateral posterior cerebral artery infarction that led to damage to the occipital lobes, except for the parts that are supplied by the middle cerebral artery. So this can happen. So they have a small pin light, a small pinhole of vision remaining.